Um, Good afternoon, good evening, good morning. Happy Friday, everybody. We're really glad to have everybody here with us today. I'm very, very happy to be handing over hosting today to Emily Yonley Phillips with MSF Epicent, who will be chairing today's IOA Network session. So over to you, Emily.
All right, thank you so much, Simone, and welcome everybody. Thanks for joining today. It's really lovely seeing all these names popping up. Amazing. This is going to be such a good discussion, I think. So today we have joining us Felicity Porritt from WHO's Advocacy, Strategy, Equity, and Health team. And she will be presenting on the social determinants of health equity, specifically looking at the communications conundrum. And we also have Julia Berenson joining from WHO to present on monitoring social determinants of health and actions to advance health equity in outbreak preparedness, recovery, and prevention. So thank you both so much for agreeing to share your work with us today. We're really delighted to have you. And following our typical IOA network call format, we'll have a few minutes for any clarifying questions directly after each presentation. But please hold your discussion questions until the end. I'll be monitoring the chat throughout, so feel free to add questions there or raise your hand at the end or jump in if I miss you. So without further ado, I would like to pass the floor over to you, Felicity.
Thank you very much, and lovely to join you all. So maybe a little bit of a different presentation from me than you're used to. Just a little bit of an introduction. My background, I'm a former BBC journalist, and I jumped to the other side of the fence, really out of frustration that I wasn't making a difference in terms of policy changes. My passion has always been around health, and I met Professor Sir Michael Marmot, who convinced me it was really worth jumping to the other side of the fence. And I've been working with Michael for the last 15 years on getting the social determinants of health and health inequalities, the messaging out there, which is a real challenge. And that's what I'm going to be talking about now. So what do we mean by health inequities? Well, they're the systematic differences in health status of different population groups. And we see dramatic differences in life expectancy between and within countries. They're influenced by social factors. That includes employment status, income, gender, and ethnicity. And the lower we are on a social position, the social ladder in life, the higher the risk of poor health. And that's what we refer to as the social gradient of health inequities. And here's some examples of those dramatic differences in life expectancy. There's a difference of around 40 years in life expectancy at birth between Japan and Lesotho. And in Glasgow, UK, Scotland, the life expectancy gap between the richest and the poorest 10% has increased by 3 years to 31 years over the past 2 decades. And the two high-income countries of the USA and the UK, life expectancy is actually falling for no good biological reason. And in the US, 3.4 million more Black Americans would still be alive today if their life expectancy were the same as white Americans. So what do we mean by the social determinants of health? Well, they're the non-medical factors that influence health outcomes. The social and environmental conditions in which we are born, grow, live, work, and age, the social determinants of health. And they're influenced by the distribution of money, power, and resources. And those money, power, and resources determine the conditions in which we're born, live, grow, work, and age. And the unfair distribution of money, power, and resources creates those health inequities. This is a graphic, very poorly drawn, I'm afraid. It's not my greatest skill, but it shows us depicts a poem written around 130 years ago titled An Ambulance in the Valley. And this is talking about whether we have a fence on the cliff to stop people falling off, or it's better to have an ambulance in the valley to scoop people up and take them off to hospital. And we're still having that debate 130 years on, yet we know around half of our health is determined by the social determinants of health, where we're born, grow, live, work, and age. So healthcare alone cannot guarantee or prolong our health, important as access to universal healthcare and primary healthcare is. So prevention, as they say, really is better than cure. If we are to reduce the influence of money, power, and resources, then we need the political will to act. And that is required from leaders of member states at country level. And here's an example of how we can get that message across. Now, I might just have to stop sharing a minute because I forgot to share sound. So I'm going to go back to here again seamlessly and show you the video.
Have made the COVID-19 pandemic far worse.
Malheureusement, les pays qui enregistrent des inéquités en santé importantes ont vu leur population vulnérable souffrir davantage du virus Covid, avec plus de morbidité et avec plus de mortalité. There really is the opportunity here for us all to come together as a global community and say, health inequity doesn't have to be like this. And so we really need to summon the world to what we know is the evidence. We know what to do.
The pandemic has been deadly, but we can learn from it. It's given us an opportunity to build back fairer.
Some of the greatest advances we've seen in our societies have come out of crises, have come out of massive disruptions.
Maybe it's time for us to step back and say, instead of trying to treat people after they're sick, we will aim to create a system that creates a healthy population that really cares about the well-being of people instead of waiting for them to get sick and then for us to treat them later.
All of our societies, we need all of our children to prosper, not just because it's the right thing to do, but that's the way we have healthy, sustainable economies. If we can't tap the potential of all of our children, we can't tap the potential of our societies.
And the evidence shows pretty clearly, the greater the deprivation, the greater the poverty, the less likely are children to have access to these positive, nurturing activities. And they contribute to the inequalities in health in adult life.
Will we summon the political will to address our greatest challenges, the challenge of poverty and inequality, the challenge of climate change, the challenge of unequal access to health services?
Améliorer la santé et le bien-être et protéger notre planète est certainement la meilleure des choses à faire pour vivre plus longtemps en bonne santé et en harmonie avec notre nature. Faisons-le, ça avantagera tout le monde et pas seulement les plus désavantagés.
Health equity benefits everyone.
Oh, and there we go again. So the WHO Commission on the Social Determinants of Health, which was a commission that published its final report in 2008 with very comprehensive recommendations on what we need to do, certainly at policy level. But it also highlighted and identified the importance of engaging public understanding of the social determinants of health as integral to effective action to improve health equity. So we need to understand what we mean by the social determinants of health equity. And the WHO's Director General, Dr. Tedros, the first of his 5 priorities is addressing the root causes of ill health. Health, he says, starts not in the clinic or the hospital, but in schools, streets, supermarkets, households, and suburbs. And that's a way of describing what we mean by the social determinants of health. And around a year ago, there was an opinion piece by one of our WHO colleagues that highlighted if we really are to make a difference, so even if we have that political drum roll for action, as we saw in that video, empowering communities with the capacity to understand and communicate the data in their own language with their own cultural norms and social norms to its members is one of the least exploited global health resources, yet it says could be the most impactful. And how do we do that? Because the social determinants of health cover the whole of society, every aspect of our life. So it's very complex, and it's about taking single focused messages and presenting a clear and concise evidential synthesis and using framing techniques such as storytelling. And that'll help policymakers, especially those outside of the areas that are familiar with the term social determinants of health, understand why they should pay attention to the SDH and prompt them to demand more evidence to help address them. And we at WHO in the Equity and Health team have devised an avatar called Lagom, and that means balance in Swedish. And Lagom explains what we mean by the social determinants of health in very lay terms. Lagom is around 10 years old, and the reason for that is that the media write or broadcast to people at the age of around 10. Also, we tried to create an avatar that was gender neutral. So here's what Lagom has to say about what we mean about the social determinants of health.
Some things in life are certain. Where I'm born and which group I'm born into will largely predict how healthy I am growing up and how long I'll live. My health, though, will depend on whether the country in which I'm born promotes its population's health alongside a stable economy and saving our planet. My health and how long I live will be influenced by my childhood experiences. I'll need to feel safe, loved and cared for, free from violence and discrimination. My health and how long I live will also be influenced by my ability to enjoy studying and reach my potential at school. So I can go on to get a job where I feel valued and I'm paid enough to live a life of dignity. As I grow up, my health and how long I live is further influenced by my local community, the air that I breathe, my access to safe, open spaces, whether I can eat healthily and socialize easily with friends. It's these social circumstances that will largely determine my ability to survive, thrive, and flourish, and to live a long and healthy life without too many visits to the doctor.
Social determinants of health and health inequities in 10 minutes. Hopefully you've gained a better understanding as to what we need to do to address and prevent ill health. Thank you.
Thank you so much, Felicity. Thank you for that wonderful presentation. And I'm very much looking forward into digging into some of those points a little bit further in our discussion. But in the meantime, does anyone have clarifying questions? I'm not seeing any.
Fantastic, I've done my job.
Very clear, very clear.
You resolved the I was going to say she resolved the communication conundrum.
Perfect. Well, I will happily pass it over to you, Julia, to continue.
Great, thank you so much. And I think Ruby is going to help share my slides. I appreciate that, Ruby, so much. Thank you. So I'm just going to briefly introduce myself and the work here that I do at WHO. My name is Julia Berenson. I am a technical officer of equity and health at WHO within a larger department called the Department of Social Determinants of Health. And a lot of the focus of my work here in the team is on monitoring and data around social determinants of health and actions to improve health equity. Another area of my work is also focused on translation of that to a research agenda that we are developing for areas for research in the social determinants of health area. And so today I wanted to talk to you about why it's important to monitor social determinants of health and actions to advance health equity, and stress the importance of that for preparing for, recovering from, and preventing crises and outbreaks. So Ruby, I don't know if you can put it in the presentation mode, because right now it's
sorry, I'm not sure why it's doing this. Apologies. Let me just
it's okay.
Stop the slideshow.
Yeah, sure. And I'll just start talking since we got the clock ticking. I first wanted to provide some context to monitoring social determinants of health in particular, and why it's important. So Felicity provided a great overview about health inequities and how gaps that are unacceptable persist, and how long people can expect to be healthy and live according to where they reside, how much money they have, their education level, skin color, ethnicity, whether they have a disability, and other characteristics. And we see across countries and within countries, health inequities persist. And they have worsened in recent years, as we have seen with recent crises, including the COVID-19 pandemic. And these health inequities persist despite many national and international actors committing to reducing them. While healthcare has a significant influence on these health gaps, the social determinants of health, which again, Felicity provided a nice primer on, have a powerful influence on health and health inequities. And much research has shown that not only the types of social determinants of health that matter, but also the interventions and policies acting on these social determinants of health, such as early education, social protection, income support, can actually create healthier and more equitable communities. So I'm now on slide 3, Ruby.
Yeah, apologies. Great. I think you're seeing the presenter view, aren't you?
Yes, it's okay. I'll keep going on ahead, full steam ahead. So as I mentioned, there have been political commitments as well as approaches focused on addressing social determinants of health to improve health equity. Nearly 2 decades ago, WHO established the Commission on Social Determinants of Health to support countries and partners in addressing social determinants of health and reducing health inequities across the world. And in its final report, the Commission proposed an ambitious agenda for closing the gap, these unacceptable gaps that I was discussing in my prior slide, within a generation. Now, as I've mentioned, the gaps still persist, and so work still needs to be done. Over the years since the Commission's report, governments have made various political commitments, from World Health Assembly resolutions to more national level commitments, as well as adopted social determinants of health focused approaches that can support policy action to improve health equity. Now, despite this evidence, political commitments and approaches, health inequities persist, and there's been slow and uneven policy action in these countries. Next slide, please. So in recent years, we see that people across the world have experienced unprecedented and interlinked outbreaks and other crises. And as I mentioned, these include the recent COVID-19 pandemic, but also climate change that is an impending crisis that continues to face us, conflict, food, as well as cost of living crisis. The health, social, and economic impacts of these outbreaks and crises have fallen disproportionately on disadvantaged populations, worsening social determinants of health and increasing health inequities. And we see this with COVID-19, as I mentioned, where disadvantaged groups such as poor populations, marginalized racial and ethnic minorities, low-paid essential workers, compared with advantaged groups, experienced higher rates of COVID-19 infection and death, lower rates of vaccination, greater barriers to care, and more social and economic disruption. Another crisis recently facing us that I mentioned is climate change. And we see with climate change also that there's a disproportionate impact on marginalized populations. So for instance, subsistence farmers, they're more likely to be vulnerable to severe weather and other consequences of climate change, which exacerbate existing health as well as social determinants of health inequities. I'm on slide 5, by the way. There, great. So these crises underscore the importance of social determinants of health and health inequities. And there's especially a need for policy action now, especially to recover, rebuild, and prepare for future crises. So as countries are emerging from these recent crises, there is an opportunity for governments to build back fair, I think as was used in Felicity's video, which is a term that Sir Michael Marmot came up with, which entails exploring how to rebuild societies in a way that benefits all people, which will be a major step in advancing health equity. Now, to inform the evidence for what policy actions need to be taken, it's really important for countries to understand the latest evidence on social determinants of health and actions for addressing them, as well as monitoring to track progress and whether or not they're addressing social determinants of health and understand actions that are needed. Next slide, please. So you might be asking, what is monitoring and why is it important? So what we mean by monitoring social determinants of health in particular is the ongoing systematic collection, analysis, interpretation, and dissemination of data on social determinants of health and actions. That entails interventions and policies, which influence health equity ultimately. So monitoring social determinants of health equity involves collecting data sources across multiple sectors beyond health. That includes agriculture, education, finance, housing, and other sectors. And all of these influence health and well-being, as decades of evidence show. Monitoring social determinants of health equity also entails not only aggregate indicators at the national level, but disaggregated indicators as well that can help to track inequalities in social determinants of health and actions by different social groups that I was previously mentioning disproportionately impacted by some of these crises that we recently are experiencing. Monitoring social determinants of health equity, and not just social determinants of health or looking at just actions, really makes that connection between social determinants of health and actions that ultimately influence health equity. And important to reiterate is monitoring social determinants of health equity is critical to achieve health equity. And this is for a number of reasons, which I'll get into later. Next slide, please. So given the importance of monitoring social determinants of health equity over the years, stakeholders at global, regional, national, and more local levels have advanced resources, tools, and other work related to monitoring social determinants of health equity. And here in this slide, I provide some examples at global, regional, and national levels. And even at the global level, for instance, WHO has undergone multiple efforts to advance monitoring related work, including about, I would say, 4 different stages of developing a monitoring framework, such as the one that I'll be discussing in the following slides that we now are advancing. So despite all this work that's been undertaken over the years, few countries systematically monitor social determinants of health and actions to improve health equity. And even fewer are using the data to meaningfully impact policy making that can close health gaps. And the most recent assessment of this was conducted in 2016 and found that 20 national systems in 15 countries had SDH focused monitoring. And even fewer countries had efforts focused on monitoring government actions to address the social gradient in health. Next slide, please. So in this context, which is health inequities persist, recent crises have exacerbated these inequities in health as well as social determinants of health, and lack of data and monitoring systems to track these social determinants of health. 2 years ago, during the 74th World Health Assembly, member states put together a resolution that called for WHO to prepare an operational framework that focused on the measurement, assessment, and addressing from a cross-sectorial perspective, the social determinants of health and health inequities, as well as their impact on health outcomes. Next slide, please. So in response to the resolution, WHO, and my team in particular and me, prepared a new operational framework for monitoring social determinants of health equity, which for ease, we're going to be calling the operational framework today. And again, that is monitoring social determinants of health and actions that improve health equity. The goal of the operational framework is to provide countries with a comparable framework of indicators and guidance for national monitoring of social determinants of action and actions addressing them, and really using this data to encourage policy action that creates healthier and more equitable communities, which is globally and applicable and harmonized. Next slide, please. So here I provide some of the aims of the framework that range from specifically highlighting key indicators and their data sources that countries can use for monitoring, to more high-level aims of providing guidance for national monitoring social determinants of health equity. We also include as an aim considerations of harmonization of monitoring social determinants of health equity at regional and global levels, such as linking to efforts of the UN SDGs. Another aim of the framework is to describe key challenges, ways to overcome them, and examples of monitoring social determinants of health equity that improve health equity from regions and countries. And finally, the ultimate aim of this effort is to propose an agenda for areas for action to support monitoring of social determinants of health equity that can improve health disparities in countries across the world. Next slide, please. So here I provide an overview of the methods of developing the operational framework. The framework builds on WHO Commission on Social Determinants of Health I mentioned that happened nearly 2 decades ago, as well as the decades of other work on social determinants of health related monitoring, conceptual frameworks, research, resources, tools, and other work. Our framework was developed under the guidance of an expert group, which consisted of stakeholders with expertise in social determinants of health. We also sought internal contributions across the 3 levels of WHO. And finally, we had consultations with member states of WHO. The draft of the operational framework was recently discussed at the executive board in January, and most recently underwent a member state consultation. We received 19 member state comments, and comments were quite positive, which is very encouraging. We recently revised the draft to address these comments and have uploaded it online, and I'm happy to share a draft of that with you in the link after I end presenting. And we finally anticipate publishing and launching the operational framework in later 2023. Next slide. So selecting a suitable conceptual framework really serves as the foundation to inform our operational frameworks, domains, subdomains, and indicators that will be key for monitoring social determinants of health equity. Our operational frameworks conceptual framework stems from existing conceptual frameworks, as I mentioned, that exist. It's not necessary to reinvent the wheel. There's been decades of work on this. And so after reviewing the various conceptual frameworks and research, we decided to include 6 measurable social determinants of domains, which first entail work, income, economic security, and income inequality. Second area is education. Third, physical environment. 4 is social and community context. 5 is health behaviors, and 6 is healthcare. And as you see, 5 and 6 typically aren't considered social determinants of health. However, in member state consultations, many member states stress the importance of health behaviors and health care in having social gradients in health. That being disadvantaged populations face challenges in, for instance, access to health care, health coverage, more so than their advantaged counterparts. So we decided to ultimately include those in our framework. And for each social determinant of health domain, there are multiple subdomains, and you'll see in the following slide, I'll walk you through an example of it. And then for each of these subdomains, there are several indicators and corresponding data sources. And as I mentioned previously, the framework includes not only social determinants of health, but it also includes actions. So we have 6 action areas that correspond to each of the domains of social determinants of health. And if we can go on to the next slide, I'll show you an example of what I am talking about. Great. So these are the proposed indicators that correspond to the domain of work, income, economic security, and inequality. And as you see, for that greater domain, there is a subdomain. There are multiple subdomains. Here we see unemployment, working conditions, food insecurity, and poverty. And for each of these subdomains, there are corresponding indicators to measure that concept and data sources, as well as notes on whether or not the data can be disaggregated by, for instance, sex, occupation, disability, age, which again is important to understand differences of these indicators based on population characteristics that can help to determine whether there are inequalities in these determinants of health. And on the next slide, you'll see the action indicators. So again, for the domain of work, income, we see there are actions that entail policies to promote fair work, income, economic security, and income equality. And corresponding to that higher domain, there are subdomains. So for instance, social policies that touch on the labor market, public policies for social protection. And for each of those, there is a corresponding indicator and data source and notes on whether or not the data can be disaggregated. Can we go to the next slide, please? Great, thank you. Oh, previous one. There we go. So I just wanted to provide an example of an area of the operational framework's proposed menu of indicators. There are many, many indicators, and I don't have a lot of time to get into all of them, but I think here I can help to provide kind of a higher level of what's included in the various indicators. So the indicators and data sources span across multiple sectors beyond health that influence health and well-being. Those sectors include education, labor, housing, agriculture, sanitation, transport, migration, public safety, and much more. The databases span a number from various UN as well as other international stakeholders, but But notably, as you probably saw in the previous pages, quite a few of the indicators come from the UN SDG indicators database. And we did that purposefully because quite a number of countries are collecting data and analyzing data on UN SDG indicators. And so it's a nice place to start for countries to monitor social determinants of health, because a lot of those social determinants of health align with the SDG indicators. And if countries are already collecting data on these indicators, we might as well start there, especially for low resource countries. The menu of proposed indicators, as I mentioned, also includes aggregate indicators as well as disaggregated indicators where available. Aggregate indicators allow for national averages and hence comparisons of social determinants of health and actions across countries. And disaggregated indicators can help to track inequalities, as I mentioned. Next slide, please. So in addition to proposing a menu of indicators, the operational framework also provides guidance to countries on, first, the process of monitoring social determinants of health equity across sectors, and using this data to inform policy at the national level. The second area of guidance includes cross-cutting approaches to support monitoring of social determinants of health equity. And under each of these areas of guidance, you see some bullet points of various action areas that we discuss in the operational framework. And in the interest of time, I'm not going to go into them because I'm seeing the clock. And then next slide, please. The next area of guidance is in relation to harmonization and monitoring social determinants of health equity at regional and global levels. So, as I mentioned, a really important area of work is ensuring alignment with UN SDGs. And so as part of that, recognizing the importance of that, the framework has a discussion on that, as well as alignment with other global resources. Next slide, please. Throughout the framework, there are a number of one more before. There we go. Thank you. So recognizing it's not only important to provide guidance on a global level, it's also important to have the voices of regional and more national experiences. We include several call-out boxes throughout the operational framework that share these experiences. And they're really powerful stories about monitoring work being done on the ground. And finally, the operational framework concludes with a new agenda for key areas and actions to support monitoring and translating data to policy action to close these unacceptable health gaps that persist in countries across the world. Next slide, please. Oh, one before that. There we go. So after the launch of the framework, we anticipate we'll be doing regional and country testing of it. The intent is not to just have this as, I call it, a document that sits on a bookshelf, or now these days the web. We want this to be engaged in the community. We also want it to be a live document that is continuously updated so that it reflects new updates to data sources, as well as experiences of countries on the ground. And to that end, we welcome engagement with countries, but we also welcome engagement with other stakeholders, such as the IOA Network and its members, who, from my quick view of the participant list when we first began, seem to come from multiple disciplines, sectors, and organizations. And I really think that will be important for helping to improve monitoring of social determinants of health equity that, as you saw today in our presentations, hopefully you're coming away with the understanding that it's so critical to have that to create healthier, more equitable communities, which again can help us to prepare for, recover from, and prevent future outbreaks and crises. And that concludes my presentation. And in the next slide, I just have my email in case anybody has any questions for me following our discussion today.
All right. Thank you so much, Julia. So much richness in that. And I think we're about to start digging into it. The discussion has already started in the chat, which is great. But wanted to open the floor for any clarifying questions for Julia real quick. No? Okay. Well, then we have two presentations that are really core to IOA. Bringing in the different data sources, monitoring in a more holistic way, country ownership, ideas about how we're telling this story, how we're using the data. So I'd love to open it up. The discussion that's already happening in the chat, should we move it into a real discussion? Ruby, did you want to launch?
Yeah, sure. So my question was to both speakers really about what is it that we need to do to affect change, policy change in terms of health, because we've known for a long time about these social determinants of health and health inequity. And I brought up in the chat, an example in the UK in a city called Bradford in the north, where infant mortality rates had become so concerning that the Born in Bradford initiative was started, and I think it's about 16 years ago actually, where cohorts of babies are followed from birth throughout life to look at a whole range of different factors, and the study is getting bigger and bigger. But my point is that and the point is to understand how health decision making is made, both from the community and from health practitioners, and to change policy in real time or practices in real time to address those concerns. But my point was, why do we need to wait until we get really concerning infant mortality rates before we start introducing policy changes for health inequity? So that's a long-winded question, but
no, it's a great question, and I think one of Felicity's slides had political will, right, Felicity, on there, and I think Felicity also mentioned this. Social determinants are about power, money, and resources, and the distribution of that, and unfortunately, a lot of people in the leadership seats, it's challenging to convince them to change those economic structures, right? And more structural determinants of health that really are driving these health inequities. So it's really challenging. And as Felicity was mentioning, I'm not sure if Felicity's still on here, but it's challenging first in communicating these issues clearly and helping policymakers to understand the importance of this. It's an uphill battle to convince them to change policies where, again, they're shifting power and resources away from the haves to the have-nots. And I think, unfortunately, it often takes times of crises, as we're seeing right now, to really call attention to how those inequitable distributions of power and resources don't work, and that they lead to more inequitable societies that make economies vulnerable. They make a well-being society vulnerable, not just the have-nots. And it's just the unfortunate reality. But on the flip side is there is a window of opportunity right now. And we saw that even with the resolution on social determinants of health that came out of COVID-19. Years ago, there was a tension in this area. Like I had mentioned, the 2005 commission report, there was a lot of excitement, momentum, and then that kind of waned. And now it's back kind of on the front of the agenda. There's another agenda item on social determinants of health at this World Health Assembly. So we're just hoping that the momentum continues. And again, it's unfortunate that it's on the backs of these unfortunate crises that really have kind of shown a light on inequities.
Yeah, I might just jump in. Hopefully, maybe put your hand or thumbs up if you can hear me okay. Yeah, fantastic. So, you mentioned the UK, Ruby, and I think the UK provides a very powerful example of, what can be done with political will and what happens when the political will drops out. So prior to 2010, there was political will to act to reduce ill health by focusing on prevention. And since 2010, there's not been the political will to act at central government level. At local government and local level, there is the political will to act, but there's been a huge cut in funding. So political will is absolutely central. And if we take two case study examples of tobacco control and climate change, what's really important in a democracy is getting that tipping point of public opinion that really wants to see change. And that takes time. The trouble with social determinants of health and health inequalities is it's hugely complex and covers the whole of society. So where do you start? So it's about taking, using storytelling by taking focused issues like the one that you suggested there, Ruby, where people can understand, actually, this matters to me. And that's what the Health Foundation with their Health Equals campaign is starting to do, to try and build the political will for change, to try and get central government policymakers to act. And you'll see that globally, as Julia was saying, and in countries where there is the political will, and if you see it in Europe and also New Zealand, around the well-being economies, that's starting to shift it as well. So the terminology sometimes I think can drag us down because in and of itself is quite difficult to understand, but it's about picking off small issues across the areas that we can really get engagement on and then get the political will to act.
Yeah, and thanks for those links, Felicity. I've already put my postcode into one of them to see what my life expectancy is.
And I'm not sure how helpful that is, you see, Ruby,
No.
because from my point of view, that's fine. You can see, actually, this is your life expectancy, which is great if you're living in an affluent area. But if you're living in a really deprived area, then what can you do about it, given that most of our health is determined by our social circumstances? You can't suddenly go out and build yourself a new home or take your kids out and put them in a different school. And therein lies the problem.
All right, thank you for that. I saw we had a hand up from Catherine and also a question from Simone. So can we take Catherine first?
Sure. Hi, everyone. Really interesting discussion. And I guess I just wanted to add to, I think, what a lot of the points that are already made in terms of political will. But, I think the importance of addressing some of this, doing it at a very large scale in terms of the policymakers working at national level is really challenging. And it's sometimes good to think about how can we do this first at a local level and who are those key players in each country that have influence on those political policymakers. So, when I worked on a project here in the US when I was first starting out in my career, and we worked with, the association of, school board members. So having that influence over the schools and the policy decisions that were made there, and then the national planning and the county commissioners, and getting all of those sort of local level folks involved. So creating this kind of momentum that would push up to the higher level political leaders. I think that could have an impact, but as everyone was saying, it takes time and it takes resources to be able to do that. And it, of course, will be different in each country context on how you go about that. But sometimes, also I just wanted to say the haves and the have-nots. Sometimes, and we've done this before with advocacy for resourcing malaria, getting those haves to be part of that, part of the solution, to be able to advocate to their peers who are these high-level policymakers is sometimes again, depending on the context, could be an interesting approach too, if they are equipped with, some of the data behind why they should even be doing this. Could be, and again, could be another interesting approach.
Yeah, definitely. The push-pull of local versus, national, which is absolutely crucial. You're absolutely right.
Yeah, and I was just going to say, you spoke to the US, which I'm quite familiar with because I'm originally from there, and the importance of involving local stakeholders. And you see in the US a lot of innovation at the local level in addressing social determinants of health and health equity. And a great resource for, I think, seeing some of that is Robert Wood Johnson Foundation. They have something called the County Health Rankings, which shows at more county, local level actions and on addressing social determinants of health. So if anybody's kind of interested more in that area, take a look at that.
All right, thank you so much. And I think we have just about enough time to dig into Simone's question. Did you want to go, Simone?
Thanks, and maybe it was more of a comment or an example. I mean, I think as well, it's an interesting thing with when we work at Integrated Outbreak Analytics, for example, here in the DRC, over the last 5 years, it's about ensuring when we are working, we're a unit inside the Ministry of Health already. So when we're trying to understand together, we recognize where are the places where, for example, recently measles and polio are recurrent despite vaccine campaigns. Across multiple operational studies that engage everybody who is there because they want to not have outbreaks in these areas, obviously. Recognizing the direct link with access to maternal and child healthcare services and so the measles one we did last week, 14 times greater likelihood of having measles if you delivered at home. But all of that and looking at those questions involves ensuring that when we co-develop recommendations, the reasons for women delivering at home in Kilwa are very different than in Tanganyika. One of them is wash related. If there's no wash services, one of them is actually much more about not being able to afford the clothing required when you're delivering, and recognizing those different issues, but then also equally co-developing at the local level and then documenting across the different provinces and countries and making sure that that co-development is happening with the actors in that area. I think we also need to be very mindful that every location context is different. The factors associating those locations and contexts are different. And that ownership comes from, first of all, when coming in to do a study is never coming in. It's always working with the people there who are saying, does it interest you? Is it a priority for you? If it is, then we do it together. And then slowly over time saying, okay, now across these 4 provinces, we've seen exactly the same barriers and social determinants of health. Now at a national level, let's make decisions. But because that comes from ownership and request, and we work in service of, it also makes a big difference. I think one of the other things that makes a big difference is this willingness to say, it's not branded by anything other than the Ministry of Health. So we have MSF, WHO, CDC, all of our partners working in support of this. But we are all doing it under the Ministry of Health. And I think that has also been something that has been very supportive to find different mechanisms of demonstrating the social determinants of health and having influence at local level first, then documenting that, and then bringing it up to higher level. And we're able to do that now with measles and polio, for example. So just another side of the coin as well. Thanks.
Yeah, no, it's interesting to hear about your own experiences, especially in outbreaks, because we're so familiar with our social determinants of health world. But there's a lot of lessons to be learned and shared from your area of work and us sharing with you. So that was interesting to hear about your process. And I mean, it can be useful even in the monitoring work when we're beginning to implement this framework, right?
Definitely.
I muted myself, but yeah, I would really love to see like how exactly that. I think part of it, we've had calls on this before, and as I was thinking about this, I was like, oh, we need another call. And like, how do we monitor the use of evidence? How are we monitoring the use of these policies and changes? So I think that that's also one of the really exciting things of going like, these things are happening, and actually we are seeing change. But how often do we get to document and share that in those ways and learn from how we do that differently across different contexts and countries and issues. So yeah, for sure. Great. And also just to the top, since I have the microphone right now over there. Great, great presentation. We'll include the links to the animations as well in the YouTube video. So
great, yeah. And like I said, I'm happy to share the link to that draft framework so you can take a look at it.
Yeah. And we'll include them in the YouTube chats on the bottom so people can access them as well. Thanks.
Okay. Wonderful. And we are just about at time, but there are some great comments and feedback from different people in the chat. So I recommend looking through. And yeah, we'll be sharing out all of this. It'll be going up on the YouTube channel. We'll have the links. So thank you so much. Thank you all for joining.
Thanks, everyone. Have a great weekend.
Thanks
for having us.
Take care.
Thanks for having us.
Thank you.
Bye.
Opportunity.
Thank you.
Thank you.
Bye-bye.
Bye.
Thank you.
Goodbye.
Thank you. Bye.